Today we are talking about Dequervain tenosynovitis. Dequervain tenosynovitis is basically a disease of a compression of the first extensor compartment of the wrist. So what happens is the abductor pollicis longus and extensor pollicis brevis tendon are there in the first extensor compartment of the wrist. So wrist has got 6 compartments. Out of that, the initial 3 compartments are on the radial side of the wrist. The second compartment consists of the ECRL and ECRB, and the third extensor compartment is the extensor pollicis longus. The fourth compartment is basically the long extensors of the fingers. So the most important here is the first extensor compartment, and if the extensor sheath is strangulating these first 2 tendons, then it is called as a Dequervain tenosynovitis. These patients will present with pain on the radial aspect of the styloid. And if you press it, that will be painful. And if you press the thumb down, this is called as a Finkelstein's test. And these patients will have a positive Finkelstein test in which if you flex the thumb like this, the patient will complain of sharp pain. So basically what it is a tenosynovitis of the first extensor compartment. Now, usually initial phases you can give a conservative trial. Occasionally, these patients, if this sheath is too tight, it may have an indentation on the bone and the radial styloid also. And occasionally, it may strangulate the tendons so that the patient will have difficulty in moving the thumb as well. So, initial phases like any other tenosynovitis, you can give a conservative trial, but if the pain is not improving, then you can advise them for a Dequervain release. So what that means, that essentially means is you need to release the first extensor compartment of the wrist. Now when you do this surgery, the surgery is pretty straightforward. You can approach it by 2 incisions. You can give either a horizontal incision or you can do a vertical incision. Both of them are fine. The most important thing that you need to take care for Dequervain tenosynovitis is you need to identify the sensory branches of the radial nerve which are right there, and if they are not identified and they are cut, they can lead to painful neuromas. So whenever you are doing this dissection either by a horizontal or by a vertical incision, you need to dissect away the branches, small branches of the small sensory branches of the radial nerve, and you should not injure or cut them. You just have to dissect on both the sides of them, and then you just identify the sheath, cut the sheath, and then identify both the tendon, both R and F, that is the abductor pollicis longus and extensor pollicis brevis. Both the tendons should be identified and they should be followed to see there is no further compression which is remaining. And after that, you can just mobilize these patients thoroughly. And you can check with the thumb movement whether these tendons are moving without compression or not. So that is very important. Occasionally, I also recommend you, if there is a dent on the styloid or the styloid is very prominent, you can do a little bit of radial styloidectomy as well to make a little more decompression for these extensor compartment tendons. So usually that is it. The other thing that you must remember is this can be associated with metabolic syndromes. So this is more common in patients who have hypothyroidism, who have lipid disorders, and who have uncontrolled diabetes. So if there is any kind of a metabolic disorder, you need to rule that out. The other thing is, as far as the conservative treatment goes, you need to do a little bit of stretching exercises and physiotherapy. That is usually within normal limits. Other treatment options, occasionally you may try with the injections in the sheath, and that actually acts with decreasing the swelling in the vicinity of the tendon. But what happens is usually it is not very effective to release the whole of compression, that is number 1, and occasionally this may lead to weakness in the tendon tissues and tendon ruptures later on. So that is one thing that we are considering. So we usually recommend steroid injection in very selected patients, and we don't recommend it on a routine basis. So preferably if the patient is symptomatic, not relieved with conservative measures, it is always beneficial to go ahead and do a simple procedure of a Dequervain release. Any questions? Thank you.